Hello and welcome to the part two of the current updates in management of Achilles tendinopathy in runners. So in the part one, we looked into the risk factors, etiology, and also we looked into the subclassification. And if you remember, we can put that into this sort of three groups: activity dominant, structure dominant, and psychosocial dominant. Now let's look into how to assess this patient in clinic and to have a good subjective and objective evaluation to guide us onto the management. Now, going into Achilles tendinopathy, we know that it's a very common problem. It's generally assumed that they get better with time, which is true. In many cases, they do with the rehabilitation, the appropriate input. But this is looking into a long-term study of patients with Achilles tendinopathy. So they looked at 43 Achilles patients with more than a 10-year follow-up. And this was mainly looking at mid-portion Achilles tendinopathy. And they completed an online questionnaire. These patients were in a different trial. And around 50% was male. So it was a good combination. The BMI was around 25. It looked at a combination of both active and inactive patients. So this is not exclusively runners. And most of them, they had a tendon thickness of around 10 millimeters. So anything more than 6 millimeters is considered to be, suggestive of Achilles tendinopathy. And what was the interesting thing was about a fifth of patients still, about 20% of patients still had symptoms at 10 years. That's quite shocking, really, because you'd expect with time things get better. And half of the patients were forced to adjust, and only a third of patients were able to be at a good pre-injury level. So it clearly tells us that it's not as easy as we thought, and maybe we need to be better from a rehabilitation point of view. We need to be better and also look into the long term, and maybe also educate the patient that the rehabilitation is ongoing. They'll have to, understand that it's not something they can just shrug off in 3-4 weeks. So that this data clearly tells us that it's more stubborn than what we thought. Now, Achilles tendinopathy happens in people as young as 20s, 30s, 40s, generally more around the 30s and 40s, and it can also happen in the elderly. And what we know is patients under the age of 55. So this is a prospective observational study. It was done in the same hospital where I work. I work as a physio at Guy's and St. Thomas's Hospital. So this was done from the foot and ankle orthopedic team. So fantastic team here. I met a few of them, and they have a really busy practice where they're dealing with a lot of complex cases here. So they looked at 320 patients who've been referred for shockwave. So Guy's Hospital is one of the NHS hospitals in London who offer shockwave, radial shockwave for patients who have failed physiotherapy. So they looked at patients who have been referred for shockwave, and what they found out was patients under the age of 55 had quite a poor quality of life compared with the general population. So the younger you are, it seems to have a big adverse effect. So think of common things which we take for granted, like walking, with the family, taking your dogs out, going on holidays. It's just not about running or just doing a 5K run. So I think, this can be quite annoying for patients because it's always stopping them from doing basic stuff, and that can have a poor quality of life. So generally, it means like this is something which we need to be aware of. So let's look into the diagnosis of classical mid-portion Achilles tendinopathy. So you have that startup pain. So when you get up, you have the morning stiffness. The previous talk, I mentioned how tendons, when they get pathological, they get fluid around. So that's the typical startup pain. And once they start warming up, it gets easier. And the symptoms, the location is very important. So if it's on the insertion, it's called insertional Achilles tendon. If it's more on the mid portion, it is mid portion, which is 70 to 80% of Achilles tendinopathy is in mid portion. And the pain gets worse as you go aggressively load. So if you go from walking to jumping to hopping, it sort of increases the impact forces. So the more the forces and the plyometric nature, the more higher levels of pain. And they will struggle with, especially with prolonged walking, running, jogging. And the pain is generally localized, so which is classical tendon pain, pain on loading, and pain on palpation. So those are the three triad of, your top three findings when you look into clinical diagnosis. And when you observe, you can observe thickening, and you can have, there's a Royal London Hospital test where if you passively stretch into dorsiflexion, the palpation decreases, and that is also common in patellar tendon. And if you do an ultrasound, you can see some thickening changes and more darkening, which I'll go through in detail. So generally, I find diagnosis is fairly straightforward. The good history, doing your functional testing and also palpation is more than adequate to making a good diagnosis of mid-portion Achilles tendon. So look at localized pain, pain on loading, and pain on palpation. Obviously, as therapists, we need to be looking into a battery of tests. So this is work taken from one of my good friends, Igor Sancho, who is a leading tendon specialist from Spain, is based from San Sebastian, been there a few times. Fantastic place if you get the chance to visit. So he's done his PhD looking into Achilles tendinopathy, especially in the running population. So this is the battery of tests which is published as part of his PhD. So you look at static calf raises, look at handle dynamometer, looking into hip extension, hip abduction, and also looking at ankle mobility. And that's important, where I'll go through the reason in the next slide. And also looking at the calf capacity, especially the soleus in seated, position as well. So we want to get a whole picture of just not only the tendon, but looking at the muscle function, looking at the range of motion, and also looking at the proximal stability, especially of the hip, mainly extension and abduction as well. Now, I did mention about dorsiflexion. Why is ankle dorsiflexion important? So we know that if you see somebody just by looking at a static evaluation, it doesn't really predict on the prognosis or the risk. But what we know is patients who have restricted dorsiflexion tend to have greater symptoms. So that's something, an important factor to consider when you're dealing with this patient. So how much is the dorsiflexion? Look at the knee to the wall, or if you have a smartphone, you could use it for inclinometer and also see whether that is something impaired as well. So again, it might have an effect on prognosis. And the research is quite clear that, when we're dealing with Achilles tendinopathy, one of the areas which we don't want to miss is looking into the strength of the calf complex, especially the soleus. So this is sort of research coming from Seth O'Neill, a leading researcher in this area from the United Kingdom. And he looked at individuals with Achilles tendinopathy, and what was very evident was when you compare runners with Achilles tendinopathy versus healthy runners, patients with runners with Achilles tendinopathy had deficits in plantar flexor strength and endurance on both the sides, symptomatic and asymptomatic, compared to trials. And weakness of the soleus appears to be responsible for the majority of the defects. So this research has two implications. One, we should be spending a lot of effort on trying to regain the strength and the endurance of the soleus. And also, many of these patients might have bilateral deficits. So we need to look at whether we need to strengthen the opposite side as well. So again, if they come with a chronic, long-standing Achilles tendinopathy pain, they might have bilateral weakness, and there could be a significant weakness in the soleus complex as well. And clinically, we need a starting point. Where should we start our rehabilitation? So this is where this piece of research from the leading Australian tendon guru, Pete Malleolus, along with Igor Sancho, was published as an open access journal. They looked into how to assess low tolerance. Low tolerance helps us to know the starting point. We want to know their pain intensity. So if a patient says, I've got Achilles tendon pain when I'm walking, running, I want to know, okay, what is your pain from 0 to 10 when you walk? Okay, they say it's 3 out of 10. So I want to know after how many minutes. So they say, if I walk for 40 minutes, it's 2 out of 10. Then they'll say, when I go for run, okay, after how many minutes of run do you get your pain? They'll say, maybe after 20 minutes of running, my pain is 6 out of 10. And when I hop, after 10 hops, the pain is 8 out of 10. So again, we want to know the intensity of pain. We want to know the activity, and we also know the duration. So that will give us an idea of where should we start. So not everybody needs to start from isometric. Some people can go straight into heavy loading and plyometric loading based on the starting point. So we can sort of put this into 3 categories based on the load. So level 1 is sort of more a low load, between 1 to 3 times your body weight Achilles load. We're talking about double leg calf raises, single leg calf raises over the step, which might put more strain, especially if you've got insertional Achilles. Knee bent, which will put more strain on the soleus. You can add external load like a dumbbell, 5 or 10 kilos, and do with fast speed. So a patient comes in, we're going to put through this whole battery and see at what level they get pain. If they don't have pain on that level 1, we might go to a bit more to the next level, level 2, where we're looking at double leg jump, walking faster, running faster, and running incline. And finally, we got that explosive testing, level 3, where we're looking at single leg hop, forward, backward, and a pogo hop as well. So this might not be appropriate for somebody who is at a very high irritability as well. So again, a patient comes in, a runner with Achilles tendon pain. We need to put them into this sort of 3 box, because it gives us that starting block. What is the pain levels? Is the pain settled within 24 hours? And what sort of loading is it? So this is more useful from a functional sort of classification rather than looking into purely risk factors. So we're looking at what level the symptoms comes in. Now, one thing which I've noticed during my travels when I'm teaching across Europe and other places is more and more physios are involved in, your having access to Achilles ultrasound scan. So I'm going to go show you a picture which sort of explains this. So first, if you look at your normal Achilles tendon here. So when I explain this to my patients, I say a healthy tendon is like uncooked spaghetti. So you can see it's sort of a straight line, bright. Whereas when you cook spaghetti, it becomes like soggy and puffy and watery. So a tendon when it becomes tendinopathic becomes thicker, sausage-like, and increase in size and loses that clear, bright structure. So we call it hypoechoic or darkened. So this is much more thicker than this normal tendon. So normal tendon thickness is around 4 millimeters. So anything more than 6 millimeters is considered to be tendinopathic. So it's more darker. And in some cases, you can also see calcification. In some cases, insertionally, you can see fluid as well build up here. So again, this is not essential, but it adds to the confirmation. So if you have a patient where you think, is it more bursitis or insertional, or, you've got doubts on your diagnosis, then a simple ultrasound evaluation in experienced hands can give you clarity. And the more thicker, the more bigger it is, then it tells you it's more chronic. And again, it's something to discuss with the patient that the prognosis can be a bit more delayed as well. So ultrasound can be quite useful in that sort of ability to give you that sort of idea of confirmation of your diagnosis. And not every Achilles pain is Achilles tendinopathy. So this is sort of a nice differential diagnosis chart here. So in chart A, the picture A, it's a patient with insertional Achilles. So the location of pain is more on the insertion, as obvious here. And this can be associated with bursitis or Hageland's deformity. And generally, they can be quite stubborn. Then you got another one, the B is the peritendinitis, which is more acute, which happens in cyclists as well, which is more the whole area. And they get worse with calf races, and they might need a bit of rest from the loading, possibly a short course of anti-inflammatory medication and gel. And the third is more medial and more higher. So this is plantaris-related Achilles pain. So this is not so common, but again, if the pain location is higher, then more medial, that might be plantaris. Then the D is the most common, which is the mid-portion Achilles tendon. And E is flexor hallucis longus tenosynovitis. I don't see this often unless you're dealing with dancers. So this is something you see in people who spend a lot of time on their toes. So again, a differential diagnosis. And the last one is a bit much more higher. It's more on the myotendinous junction. With this group tends to do very well and tend to have a quicker diagnosis. So again, it's easy to label everybody as Achilles tendinopathy. So let's always look at the diagnosis, especially if they're not improving, and seeing whether is it other categories as well. So how do we put all this information together? And if you want a simple assessment sheet to sort of highlight your overview. So this is sort of a chart which we created for the participants of the Running Rehab online course. You'll also be getting a handout of something which you can use in clinic. So it's tend to be comprehensive. I'm not saying you need to do this for every patient and you need it all in one go. So a patient comes in, so look at the history, what are the risk factors? The first thing is looking at their load tolerance. At what level are they? Are they at level 1 with simple calf raises, or level 2 with the jumping, and level 3 with single leg hops? So that gives me an idea of the function they are in. And then looking into their range of motion, looking at the knee flex, knee extension, we want to make sure that the muscle mobility impairments are picked up. Then looking into capacity, how many calf raises they can do single. Can they do at least 20 to 25? Single rise test, sit to stand, one leg sit to stand. Generally in runners, I like to have them at least 20 plus. How about their posterior chain, single leg hamstring bridge? How much can they do that? And submaximal hopping. So when you do repeated hopping, how is the response? And also looking into testing in the gym. So especially with seated calf raise. So ideally, we know from research they should be doing at least 1.5 times their body weight, single leg, with the seated calf raise, and with the leg press and the knee extension, hamstring curl. And if you have access to a handle dynamometer, looking into their hip abduction, extension, knee flexion as well. So again, looking into all those factors, looking at the kinetic chain, looking at hip function, looking at the capacity of the calf complex, the hamstrings, and the whole posterior chain as well. And then looking into plyometric explosive strength. What is their single leg hop? Is there much difference side to side? If they are at high level, you might do a triple hop. And if you have access to force plates, you might look at the vertical height and the counter movement jump, look at reactive strength index. And let's not forget about patient-reported outcomes like the VISA A, and also fear avoidance, Tupper kinesophobia scale. And if you do have access to ultrasound, checking if they have got tendon thickening, focal hypoecosity, tendon calcification, and neovascularization as well. So nice slide from Karen Silbernakel, who is a leading authority on this area, is to look at tendon health in 4 components. We're looking at symptoms. That's why they come to us: pain, stiffness, and patient-reported outcomes. Look at the structure, which is generally visualized with ultrasound. Look at the morphology, mechanical properties, and looking into function and performance, looking at calf muscle performance, jumping, running. And finally, let's not forget the psychological element, which has been shown to be quite important in many patients, especially with chronic symptoms. So putting all this together gives us a good overview of where the patient is, and that'll enable us to sort of give us having a good, robust rehabilitation program for our patients with chronic Achilles tendon. So that concludes part 2, where we look into the diagnosis, comprehensive evaluation of all the 4 components of tendon health. In part 3, we're going to look into how do we get this patient back running, because at the end of the day, we can have the most complex evaluation, but the patient is interested in getting back into running, and also to do it safely and with less pain. So we'll be looking into early stage. What are the stages we can look into? Advice on footwear modification, what exercises, and look into the strength phase. And then plyometric phase is extremely important. So what plyometrics is suitable? and return to running. So at what phase we need to get them back. And there'll be a significant proportion of patients who will not respond. And in those cases, do you want to consider things like injections or shockwave or other options which might be suitable? But generally, we know that surgery is not a suitable option. So generally, we want to exhaust a good quality rehab. And if that fails, we might look into other adjuncts which might be suitable in a small group of patients as well. So hopefully, that sort of gives you the whole journey of a patient right from diagnosis. And I hope to see you on my talk in phase 3, phase 4, and phase 5 of the comprehensive Achilles rehab or evaluation in recreational runners. So that concludes part 2, and look forward to part 3, 4, and 5, 6 on the running rehab course in association with PhysioTutors. Thank you for your time and attention.